Medical education prepares you exceptionally well for clinical uncertainty. It does almost nothing to prepare you for the slow erosion of a career. The acute threats, adverse outcomes, malpractice, licensing issues, those get attention. The chronic threats are quieter. They accumulate over years. And by the time they're visible, they've already done significant damage. Here are the four that no one warns EM physicians about early enough. The first problem is the career arc assumption that a full time clinical career in emergency medicine is sustainable for 30 or 35 years on the same terms you started with. The data does not support this. Emergency medicine has one of the highest burnout rates of any specialty. Physical demands, irregular sleep schedules, high intensity shifts, prolonged standing, acute stress exposure accumulate in ways that compound over time. The physicians who sustain long careers in emergency medicine almost universally do one of three things. They reduce clinical density over time, they layer in non-clinical roles that provide variety and recovery, or both. If your career plan is to continue at full clinical intensity indefinitely, you need to look at the data on who actually does that. It's a smaller cohort than the plan assumes. Sleep disruption in emergency physicians is not episodic. It is structural. Overnight shifts, rotating schedules, circadian rhythm disruption, these are not occasional inconveniences. They are features of the career that most physicians underestimate in their long-term health calculus. Chronic sleep disruption is associated with cardiovascular disease, metabolic disease, cognitive decline, and psychological morbidity. These are not theoretical risks. They are documented outcomes in shift workers followed longitudinally. The physician who tracks nothing else about their health should track sleep, not as a wellness exercise, as a professional self-assessment tool. Your cognitive performance is your clinical asset. Protect it. The second quiet risk is identity fusion, the progressive conflation of professional identity with personal identity until the physician and the clinician are indistinguishable. This seems harmless. Many physicians consider it a sign of commitment. It becomes dangerous when the clinical performance is under threat, from burnout, from a bad outcome, from a licensing issue, and the physician has no self-concept outside the role. Emergency physicians who have meaningful identities outside medicine as parents, athletes, teachers, veterans, whatever the dimension is, demonstrate greater resilience under professional stress. The non-clinical self is not a distraction from clinical excellence. It is a buffer against its loss. Emergency medicine moves. Point-of-care ultrasound capabilities expand. Pharmacologic protocols update. Resuscitation science evolves. The physician who finishes residency with a complete skill set and does not deliberately invest in continuing development will find that skill set increasingly outdated within a decade. Simulation medicine, procedural skills maintenance, fellowship-level training in subspecialty areas, these are not just academic exercises. They are career longevity tools. The physician who is current is more confident, more competent, and more engaged than the one who is not. Continued skill development also changes how administration views you. The physician who is visibly investing in professional development is harder to replace and harder to dismiss when resource conflicts arise. Shift work erodes relationships. Not because emergency physicians don't value their relationships, most do deeply, but the structural incompatibility between a rotating shift schedule and the social calendars of people who work 9 to 5 creates chronic friction. Missing dinners, weekends, holidays. Being unavailable on a predictable schedule. Having energy for professional demands and not enough left for personal ones. These are not failures of character. They are foreseeable consequences of the schedule. Acknowledging this risk early allows for deliberate mitigation, intentional scheduling of recovery time, honest conversations with partners and families about the demands of the work, and the discipline to protect personal time with the same rigor applied to clinical time. The framework is straightforward. Think of your career as a system with inputs and outputs. Clinical output, patient care, education, leadership, requires inputs, sleep, recovery, relationships, ongoing learning, identity outside the profession. Most emergency medicine training optimizes the output side intensely. It does almost nothing for the input side. The career that lasts is not the one that maximizes output in year 1 through 10. It is the one that manages the inputs well enough to sustain output through year 25. That is not a wellness platitude. That is applied systems thinking for a career in a high demand specialty. This is Global MedOps Command Clinical Brief Series. The risks that end careers quietly are the ones that aren't discussed until after they've done their damage. Build your awareness early. The physician who sees the risk coming has the best chance of building a career that lasts. Next brief. What hospital administrators mean by efficiency. Stay prepared. Stay educated. Out.